Hello, this is Dr. Steve Johnson, and this is Short-Term Counseling, Module 6. In this module, I will be discussing the treatment of anxiety, depression, and anger. One of the important concepts before we jump into treatment is the concept of scope of practice. Every profession has a scope of practice. Some are defined by professional ethics. Some are defined by professional ethics as well as state law that determines what the legitimate scope of practice is. And the scope of practice is really an indication of what you may within that profession do and not do. So for example, in treating mental and emotional disorders, you can only diagnose and use appropriate treatments if the individual is licensed by the state. In most states, clergy, chaplains, and unlicensed care and counseling professionals may not diagnose, nor should they use the treatments that other than religious practices. And then to act outside or to engage in activity outside one's scope of practice can be against the law and put you at significant risk for litigation. So please stay within your scope of practice. Also, related to this, but overlapping this, is that it is very important that when we are within our scope of practice and someone needs treatment or care beyond what we are permitted to do within that scope of practice, then it is really important that we make an appropriate referral. Now, we who are licensed mental health professionals refer to other licensed mental health professionals because we all have our individual scope of practice. No one of us can do everything. So for example, as a psychologist, I might refer to psychiatrist for diagnosis and medication evaluation. You may find it necessary to refer to a psychologist for diagnosis and psychological testing. Clergy, chaplains, and care and counseling professionals may also refer to master's level counselors, such as licensed professional counselors or marriage and family therapists or addictions counselors, for certain kinds of cases. We do this to create a safety net for our clients that protects them, because all of us have one basic requirement, in that we are to avoid doing any harm to a client whatsoever. And practicing outside our scope of practice may maximize the possibility that we will do harm. And it also can be harmful for you, particularly if you, get sued and you lose the right to or the privilege to practice anymore. That can be unpleasant. So let's look at what do we do before we look at treatment when we are addressing an emotional crisis. So I'm talking about the case where an individual presents in our office, and they're experiencing major distress, experiencing, like deep, painful emotions, and especially behaviors that may be sabotaging them in reaching their life goals, those personal, professional, interpersonal, and spiritual goals. Then we would need to make an appropriate referral to a licensed mental health professional. If, however, you see someone or you're talking to someone on the phone or otherwise, you have the suspicion or the individual states that she or he is suicidal, then you need to do the following immediately without letting the individual out of your sight or without hanging up the phone or whatever. You need to call 911 or the police immediately, or you have to arrange to have that individual taken to the nearest hospital emergency room. Again, immediately. If they say they promise they're not going to do anything, but they've stated that they are suicidal, then you need to take action. Let's move to treating anxiety. Remember, when I covered the REBT theory of emotions, I said that there were two forms of anxiety: ego anxiety and discomfort anxiety. In ego anxiety, the individual has the belief that there's a threat to their individual self-worth or to their life. And in discomfort anxiety, there's not that level of threat, but they believe that there's a threat to their individual level of personal comfort. Okay, so to know how to go about treating an individual with anxiety, you need to know the following, and most of this is what I have already covered in the course. You're going to have to know inside and out the REBT theory of emotions. I've stated that more than once, but it is really important at this stage in the course that you know that theory of emotions inside and out, and that for every dysfunctional emotion that presents by a client, you need to know what the inferences are that undergird that emotion. You need to know the unhelpful beliefs that are associated with it, and the action and behavioral tendency of an individual with that particular emotion. You also need to know what the alternative functional emotion is. So for example, in the case of anxiety, the alternative functional emotion would be concern. And in addition to knowing the REBT theory of emotions and all of those aspects, you're going to need to know how to use the types and styles of debates, which I've already covered. And as part of that, you're going to need to know how to do an inference chain so you can help the client move from the inferences that they're making to the actual unhelpful beliefs there, because we need that in order to move to treatment. So let's look at the treatment strategy. Well, in this lecture, we will consider both the cognitive and the behavioral strategies that are designed to replace unhelpful negative emotions with helpful negative emotions. And some people say, well, why aren't you replacing the unhelpful negative emotion with a positive emotion? Well, the reason is that sometimes it's not helpful for the client to have a positive emotion. Let's say that the event is a very negative event. We don't want to be happy about a very negative event, otherwise we may not take appropriate action. The other one is that it may just be unrealistic to have the client go all the way from an unhelpful negative emotion all the way to a positive emotion. We find it easier and actually more helpful if we move from an unhelpful negative emotion to a helpful negative emotion. Again, for anxiety, which is an unhelpful negative emotion, we would try to help the client move toward concern rather than move to the positive emotion of happiness. So one of the ways that we're going to do this in terms is, through our cognitive strategy by debating and replacing the dysfunctional beliefs. And we looked at the types of dysfunctional beliefs in the model. We'll also develop some behavioral strategies. This is so that we have the client act in more functional ways than in the dysfunctional ways that are associated with the dysfunctional emotions. So that's going to be tremendously important. And if we know the theory of emotions, then we know what that action or behavioral potential is with the given emotion, so we can already be thinking about an appropriate behavioral strategy to use with a particular client with a particular emotion. So in anxiety, remember that the inference that the client makes is that there's a threat to their being or to their discomfort. The typical unhelpful beliefs that are present with anxiety would be a demand, right, that threat must not happen, and the frustration and tolerance, the belief that if it does happen, that they wouldn't be able to stand it or tolerate it, whatever. and that the action or behavioral tendency with anxiety is to avoidance. We tend to avoid those situations or people about which or whom we make ourselves anxious. So one of the ways that we do this is to use cognitive debates. And we've already covered those, so I'm not covering them again in this particular lecture, except to say that use all of those debate forms. The pragmatic or functional, empirical, logical, and friendship debates, and then vary the style. Remember, we said the Socratic and didactic and metaphoric or story, those, or even humorous kinds of styles, and we said that probably the most important there would be the Socratic style. Doesn't mean you do that all the time, but the Socratic style will have more engagement on the part of the client, which we always want. If you are studying to be clergy or chaplain or a care and counseling professional, then you're going to confine your debates to those that are religious in nature, okay? And remember that the beliefs that we will be debating will be twofold, or teaching the client how to debate will be the demandingness, because demandingness is going to be present in every form of dysfunctional emotion. And then the one that is quite common for anxiety is frustration and tolerance. They believe they can't stand it or tolerate it. And so we would need to work at that level and use the debates to overcome those two primary dysfunctional beliefs associated with anxiety. The behavioral intervention kind of differs. If you're going to be a licensed professional, then since the action or behavioral tendencies associated with anxiety is avoidance, then often we're going to use a treatment to help the individual overcome avoidance, and that usually is some form of exposure therapy. Have the individual do the very thing or encounter the very thing, whether in reality or in imagination, the thing about which they are avoiding. If you're not going to be licensed, and we've already covered those professions that aren't, then you can appeal to a verse like casting your anxiety upon the Lord because he cares for you. And you might have the client do that, visualize ways that they could cast that anxiety upon them, upon the Lord. For example, here's one way. I remember when I was in Romania with really strong Christians, but they were kind of shy and they wouldn't go out there and witness to people, etc. Even in non-intrusive, not belligerent ways, but in very nice ways. They wouldn't even do that. So exposure there might be just to have them to take measured risk to share with an individual their faith. Again, not in an intrusive way. It is very important for me to state that if an individual is experiencing really inordinately strong anxiety that's not only painful emotionally, but getting in the way of attaining their life goals, you need to make a referral to a licensed mental health professional. And if there's a suicide, if you have the sense that suicide is an issue here, or if they voiced it, then of course take the appropriate action, as I've already covered. Let's move to treating depression. Since an individual who suffers from major depressive disorder constitutes the largest group of individuals that complete suicide, and then the percentage of those individuals with major depressive disorder that attempt suicide is around 10%, which is rather significant when we realize that at any point in time there are at least 25 million Americans who experience major depression, and 10% of 25 million is a huge number. So it is extremely important that we refer a depressed individual to professional mental health provider, licensed mental health provider, to make such an assessment. And however, it is important that clergy and chaplains and care and counseling individuals if they're going to be part of the help, that they form a collaborative relationship with the licensed mental health professional, so that, each of them, the licensed mental health professional and the unlicensed one, provides some vital support during a difficult time, and the spiritual resource can be tremendously important. In fact, it is really important for unlicensed people to be on top of this, because more individuals, go to clergy than they do a licensed mental health professional as the first stop. So clergy are going to provide a really important, be a really important resource of referral and ongoing support during treatment. So in depression, remember that the inference is that there is a loss, a very significant loss, personal loss to the individual. The beliefs tend to be some sort of demand that the loss should not have happened, that the loss, the derivative would be awfulizing or catastrophizing, that this loss should not have happened. It's awful that it happened. And then that there's usually negative global self or world rating in the depression. We tend to beat the self up and get very and have negative evaluations of the world and life as a result of the loss. The action or behavioral tendency associated with depression is not so much avoidance, but it is withdrawal from life, withdrawal from those activities or those individuals that were sources of pleasure. And so the individual withdraws from them and kind of hides from life in many ways. The cognitive debates here, we're going to use all of them: the pragmatic, functional, empirical, logical, friendship, and within all the styles. And then the clergy, etc., or the unlicensed, are going to use kind of religious interventions. And remember the book that I wrote that is required for you to read will have those kinds of religious interventions in there. The primary dysfunctional beliefs that we're going to need to debate, whether those are gone through religious interventions or non-religious, would be demandingness, awfulizing or catastrophizing in the global negative self or world rating. The cognitive goal, and this is very important to remember, the cognitive goal for someone who is experiencing depression is, instead of engaging in global negative self-rating, we want to help that individual unconditionally accept the self. We're not saying that they like every trait about the self, and we're not saying that they like their behaviors. In fact, they may be very dedicated to change those behaviors. But you'll do a much better job of that if you unconditionally accept yourself, regardless of your faults and foibles and failures at times, okay? It's not helpful if we have faults to say that we are nothing but a fault, or if we fail at something to declare, overgeneralize and say that we are a failure ourselves. We want to help them move toward unconditional self-acceptance, which is how God views us. But often we only conditionally accept ourselves based on our performance or whether someone likes us and those kinds of things. So it is much healthier if we move toward the unconditional acceptance of the self. So how do you do this? Well, one of the things that my best friend, Dr. James McMahon, who just died a couple of years ago, and I worked on, and we have a very simple intervention for individuals who are depressed. This is, we make a distinction, and it's important for the clients to make a distinction between the self and the roles that they have. So I diagram the self in kind of like that oblong there, right? Self. And the self we are not going to evaluate in any way. We just accept the self. However, we will look at the roles that we have as an individual. And we all have different roles. I have a role as a professor, um, uh, the husband, father of 2 daughters, subscriber to the New York Times, any number of roles. And what is helpful is if we evaluate our performance within that role. So for example, maybe I said something that wasn't real helpful to my daughter. So I might evaluate what I did is negative and not really helpful. And so evaluate that and think of a way that I could improve in my performance within that role, but not evaluate the self based on my performance in the role. Now, if you look at the lines in this slide, you'll see that some of them come much closer to the self than others. And this is to signify that there are roles that we really value. So for example, I really value my role as a father. And so that if I make a mistake in that role or I don't perform well, I'm much more likely to beat up on the self and globally negatively rate the self, which is not helpful. So the more important the role is, the more likely we are to globally negative evaluate the self, again, which is not really helpful. It's much better if we just focus on improving our performance or our behavior within a role. So if we can have clients disengage the self from their roles, then we can get them to be much more resilient and lower the incidence and the intensity of that depression. A behavioral intervention that we have in the face of depression is, well, we already know that the action or behavioral tendency for depression is withdrawal. And so the behavioral intervention here is an intervention to overcome this withdrawal and have them engage with life. So let's look at that. One of those that Aaron Beck, the founder of cognitive behavioral therapy, developed is part of this treatment for depression. It's designed to help a depressed client engage in an activity that is pleasurable. And it's best if it's one in which the client does not have full mastery. Why? Because the point is to try to have the individual kind of unconditionally accept the self and experience pleasure rather than avoiding pleasure, even if they're not perfect in their mastery. So some examples of some activities that a client might be able to engage in to learn this is some kind of physical exercise. So I remember when I was taking aerobics, I just couldn't do some of those moves very well at all. I'm just kind of a discombobulated individual anyway. And so it was really good for me to be in there with people who were they'd really mastered some of those movements that I hadn't, but at the same time to note that I was enjoying this and that when I evaluated myself negatively, that the pleasure went down. So better that I experience the pleasure and note that without the evaluation, because I would be robbing myself of the pleasure. So it's very helpful for that. Or you could do that with your participation in a team sport or singing or playing a musical instrument, acting, dancing, carpentry, working on a car, anything where you haven't fully mastered it, but you kind of like doing it. If you hate it, don't do that one. I mean, do something that when you're not depressed is a pleasurable activity. And one of the things that we do when clients engage in this activity, we ask them to rate the amount of pleasure that they experienced, so that if they experience any pleasure, that's better than the withdrawal from that activity that they tend to do when they are depressed. So this is an ongoing process. Let's shift to treating anger. Remember that treating anger can be pretty challenging because people who are angry tend to focus on the wrong thing. They tend to focus on their perception that an injustice has been done to them, and their response to that injustice is just not helpful, anger. Thus, But the problem is that the individual who's angry believes that they've, again, and focus on what they think is the fact that they are justified in their anger. And they may well be justified in their anger. But it would be much more helpful to focus on whether that anger is helpful and gets them some better connection with another person, and maximize that the individual doesn't do the injustice about which the angry person is angry. We're not asking the angry person to give up their values of justice. No, maintain those. Wanting justice is not the problem. That's actually quite wonderful. It is the demand for justice and getting angry about the justice that kind of messes it up and doesn't get you what you hope that you will get. So, in anger, there are certain inferences, 3 general ones. One, that you were blocked in reaching your desired goal, that something is in your way. 2, that somebody has transgressed, or an institution has transgressed some non-moral rule that you have, okay? And then that another one would be that there's a threat to your self-esteem, that somebody is like putting you down, or something of that nature, calling you names. And the beliefs that we usually see with anger, of course, demand, which is always going to be there. But the demand here is that person should not have transgressed that rule. They should not have blocked you, and they should not have said what they said about you. And when they do, the individual who's angry tends to globally and negatively evaluate or rate that other person, which is not helpful. Just as unconditional self-acceptance can contribute to depression, the unconditional acceptance of the unconditional acceptance of the other can help overcome anger. And again, the action or behavioral tendency is to kind of verbally or physically attack that other individual that we think has done us an injustice, or transgressed a rule that's important to us, or threatened our self-esteem by calling us names or whatever. So the cognitive strategy, of course, is going to debate the demand and replace that with a preference, and then to debate the global negative evaluation of the other person and replace that with the unconditional acceptance of the other. So you see, with depression, we're working on the unconditional self-acceptance, and typically with anger, we're going to be working on the unconditional acceptance of the other person. One of the things that you can do, and we do this in REBT, is have the client, this is a cognitive strategy, is to have them complete an anger episode record. And I will post this on Canvas so that you can see it. This is where we have, in a systematic way, in a 4-page form, so it's rather exhaustive analysis, is have the client identify and rate different aspects of their anger, the behaviors during their anger, the cognitions, the emotions, both the short-term and long-term consequences, positive and negative, and then the overall helpfulness of the anger once you've evaluated those short-term and long-term positive and negative consequences. Was it worth it, or do you think it would have been better to have not had that anger, or maybe frustration or annoyance rather than the anger? Okay, so it's a very, very helpful cognitive intervention to use. The behavioral strategy, and remember this one, the behavior is to move toward and engage in behavioral or verbal aggression. And so one of the things that we try to do is make a distinction among aggression, passive aggression behavior, and assertiveness. Aggression and passive aggressiveness are not helpful. And the basis of them are beliefs that are generally not helpful. And I will, again, post on Canvas a form that lets you see these differences, that compares and contrasts these. And what we want to do instead of aggression is to have the individual engage in assertiveness. So, part of that process is to identify the unhelpful negative beliefs associated with the aggression or the passive aggressiveness, and then have the client practice the assertiveness skills, the behavior, and maybe even changing even those cognitions that mark assertiveness. Now, having said that, it is really important to make a distinction here. Some people go through like assertiveness training, and they think that in every situation where there seems to be an injustice done to them, that they absolutely must be assertive. And REBT would say that is just another form of irrational demand. There is no necessity, there's no absolute or must that you have to be assertive. Frequently, assertiveness is helpful, but sometimes assertiveness is not helpful. So, for example, I think as I gave an example in a previous lecture is, what if you have a boss in a job, and you really need this job because it's, maybe you've got children, or a disease that requires medication that can be kind of pricey, or any number of reasons why you might need that job, and the boss is just not the easiest person to get along with, and sometimes they're unjust, but the boss, and that if you act assertively, that the boss does not take that very well and may even fire you. So you have to make an assessment. What's in your short-term and long-term best interest? Maybe you decide that it's in your short-term best interest right now, at least, to tolerate the injustice. I mean, we're not talking about them harming you physically. That's a whole different ballgame, or abusing you. But non-abusive kinds of behavior, and they're being unjust. Maybe you tolerate it and not upset yourself about it so much, and look around for another job. And then when you get that, then you make the move. Of course, if it is really unjust and abusive, then you may need to take some action, and then maybe that's what's in your short-term best interest. But it's better if you consider what's in your short-term best interest and long-term best interest, rather than going, I absolutely must be assertive all the time. Okay, that ends consideration of what we do in terms of treatment for, or at least some treatments for these emotions that are going to be very commonly experienced. Okay, so if you have any questions, feel free to email me, and I will be happy to respond. Thank you, and have a good day.